So today we are going to talk a little bit about nystagmus. Now I know this is a topic which is a little bit confusing, and the main reason is that you really studied in different parts, partly in neuroanatomy, partly in ENT, partly in neurology. And in order to understand it, you need to go back and cover the basics, and then I promise you it will be easier. So bear with me as we cover these basics. Now, first of all, we need to talk about the vestibular system and its function, right? Now, what does your vestibular system do for you? It really has three functions. It keeps your equilibrium, it helps you maintain your posture so you don't fall down, and what is super important, as we later on talk about nystagmus, the vestibulo-ocular reflex. Now, let me give you an example to better understand how what this vestibulo-ocular reflex is, because the other two you kind of intuitively know about it, right? If the wind is coming and you're on your bike, you need to kind of lean towards the direction of the wind to keep your posture. Or if someone pushes you, you would extend one of your legs in order to keep your posture. To keep your equilibrium, you would contract your core muscles and your proximal muscles of your legs and your hands to keep your equilibrium. But how about vestibulo-ocular reflex? Now, in a nutshell, what that is that it helps you keep your visual field level so it doesn't bounce around so much. Now, for example, you could run up the stairs having your imagine these are the steps and you're running up the stairs and your iPhone is in your hand, and then go back and watch the video from your iPhone and you see that the video is just jumping all around the place. And today's cell phones actually use image stabilization techniques. Even with those, the image is jumping all around in the video camera. But this does not happen to your eye as you're jumping up and down the stairs. Why? Because your vestibular system senses the movement and your brain will compensate by moving your orbit, by moving your eyeball around in order to set off that movement. So your visual field is not jumping up and down like the one in the video camera, right? Now, we will come back later on to this vestibulo-ocular reflex and talk about it in more details. But I just wanted to say VOR is the main reason why we have nystagmus and why nystagmus happens, but we will come back to this later on. Let's go back to our basics a little bit. What are the components of the vestibular system? Okay, now it's a sensory organ, so you need to have some sensor, right? These sensors are referred to as the vestibular end organs, written here. Vestibular, let me change the color. Vestibular end organs. And you really have two types of vestibular end organs. You have the semicircular canals, you have three semicircular canals, and you have two other systems called the utricle and the saccule that actually sense the linear acceleration, but the three semicircular canals sense the angular acceleration and movements. Now, look at this image on the top right corner. This is a horizontal section through your skull, right? This is the foramen magnum here. This big one here is the foramen magnum. And this would have been the petrous bone, right? The pyramid. And the apex of the pyramid is directed anteromedially. So now you should know this direction is actually anterior direction. And we have cut off the petrous bone so you can see inside. And inside you see these five vestibular end organs, right? You see these three semicircular canals here, and just like the three directions of the Cartesian coordinate systems, you need three different directions to sense movement in this space. And these three semicircular canals are directed relatively vertical to each other, or I should say perpendicular to each other, right? The one which is located along the axis of the pyramid is the posterior one, right? So this is the posterior semicircular canal, the one which is along the direction of the petrous bone. This would be 45 degrees relative to coronal section, and also 45 degrees relative to the sagittal section, right? And let me delete this stuff. And perpendicular to that, almost perpendicular to that, you have the anterior one. So the posterior one and the anterior one. So easy, right? And the third one is actually also perpendicular to these two, and it's located in the horizontal plane, right? So this is this one. Also, sometimes they even call it the horizontal semicircular canal or the lateral semicircular canal, which is in the horizontal section. Now, there's a caveat here. It's not really completely in the horizontal section, and I would like to tell you about it because it is important, clinically important, all right? Imagine this is the head of a person, right? Dead straight. They're looking dead straight, right? If the semicircular canal, if the lateral semicircular canal was completely within the horizontal plane, from the lateral view, it would have looked something like this. And this is not the correct position, right? I mean, just this is a very rough graph. It would have looked something like this. But it's not really. It's kind of tilted upwards for almost 30 degrees. So it actually looks like this. 30 degrees tilted upwards compared to the horizontal plane. And this is important because sometimes we perform a test called a caloric test, where we put warm or cold water into someone's ear, and that will make the movement of the endolymph within this canal, and that will call nystagmus. But in order for the test to be accurate, you actually need to tilt the person's head 30 degrees forward for this canal to be in a completely horizontal direction. So we kind of sometimes do this on unconscious patients to determine if they are brain dead or not. And the patient is supine, obviously. They're on the bed, they're lying on their back, supine position. Then you would have to tilt the head forward for 30 degrees. A movement which moves the chin towards your chest, right? 30-degree anterior flexion. And then that would actually position the semicircular canal in a completely horizontal direction and maximize the efficiency of this test, all right? So that's why it was important, because in the wards, when you're doing the caloric test on unconscious patients, you kind of need to put a pillow under their head and make the approximate 30-degree flexion, all right? Now, within these canals, look at this lower image here. Within these canals, you have endolymph. It's a fluid with a particular component of electrolytes, which we do not want to talk about here right now. But where the magic happens, where the sensation of movement happens, is where these canals actually reach the utricle here, as you can see here. You get this dilation of the canals, which are referred to as ampulla, right? Ampulla. This is in these three ampullas is where the magic of sensation happens. Now here I have the picture of an ampulla for you. This is ampulla, right? The dilated section at the end of these canals. And you can see these sensory cells. These are hair cells, because on their apex they have these ciliary projections, which can move around. And at the base of these cilia, you have ion channels, which can open and close as these hair cells kind of move around or move back and forth. So this is called the crista. The crista is where the sensory cilia of the sensory cells are located. And on the top of it, you have something called cupula. And what cupula is kind of a gelatinous material, and it has a little bit of more weight to it. And this weight is important because when your health is moving around, this endolymph, the fluid, and consequently this gelatinous material will lag behind. It's kind of like when you have a half-filled, this is an awful bottle. Imagine a bottle of water, right? And it's half filled, and you kind of move it around. The water inside has an inertia, which means basically its movement lags behind that of the bottle. So it keeps hitting the wall of the bottle. The same thing happens here. The endolymph and consequently the gelatinous material do not follow the movements of the canal in time. They're lagging behind. And as they lag behind, they will actually transmit this movement to these cilia, and these cilia will open or close the ion channels, and these cell bodies here get depolarized or hyperpolarized, and those are providing the signals. And you're like, hey man, what the fuck are you talking about? Hyperpolarized, depolarized. So which one is it? Is it hyperpolarized or depolarized? Which takes us to this note that I put here, push-pull system. What does the push-pull system mean? It means imagine that this is your head, okay? This is your nose pointing forward, this is anterior, this is your eyes, and imagine this is the horizontal canal on the right side, and this is the horizontal canal on the left side. Normally they are both providing signals. So imagine this is zero activity here, zero activity here. They do not have zero activity. Even at baseline, when your head is not moving to the right or to the left, it's dead straight, it's dead ahead. These are providing some amount of activity, a basal activity, right? So I put basal tone, for example, here. Basal tone. What happens when you tilt? Let me change the color here so you can see it better. What happens when you tilt or rotate your head to the right? When you rotate to the right, what happens is that the endolymph moves in mirror images in the right and left side. So the tone in the right side increases and the tone in the left side decreases. So you get depolarization here and hyperpolarization here. And this is the signal, right? This is the so-called push-pull system. One side gets depolarized and the other side gets hyperpolarized, so the membrane potential becomes more negative, and the depolarized when the membrane potential moves towards positive and becomes more positive, right? Now you might ask, why is this working like that? Well, let me give you a simple example. Imagine you have a car which is not moving, right? And you want to move, you can push the gas pedal, right, for it to move. But imagine another car which is in a stationary position, it's not moving, but you're pushing the gas pedal, and at the same time you're also pushing the brake pedal, and the forces are canceling each other out, so your car is not moving forward. Now, if you want to make it go forward, you have two options. You can let go of the brakes or push the gas pedal further, right? But imagine if you did both of it. If you put the gas pedal or press it even more and release the brake pedal, you will move much faster in a right. So your initial let's say drag race would be much faster if you're pushing the gas pedal and the brake pedal. When you're doing a drag race, you would want to do that. And it's the same story here. Having a basal tone on both sides allows us to respond in a so-called in a basically more amplitude, respond into a greater manner to a certain amount of movement, right? Okay, I hope I could explain this to you in an understandable way. Let's move on to the next set of sensory organs. So we talked about the end organ and organ systems, which is the sensory part. We talked about the three semicircular canal, the directions of each of one, and the sensory part of the semicircular canal, which are these ampullas here. Now we have two other, and the semicircular canals, they can sense angular acceleration, right? So rotation in different directions, not linear movement. So how do we sense the linear acceleration? We have two other organs, right? These are the utricle, this one, let me clear this image here. The utricle, this larger one here, and the saccule, the utricle and the saccule, right? And the sensory part of the utricle and saccule are called the macula. So consequently, we have two maculas. We have the utricular macula and the saccular macula, right? Kind of easy. Now, what do these sense? Well, as you can see, the utricular macula in this image, the utricular macula is lying kind of in the same plane as the lateral semicircular canal. So it is sensing horizontal movements, right? So if you're sitting in a car and the car moves forward, this is what will give you the sensation of forward movement. But if you're in an elevator and an elevator moves upward, the saccula will give you the sensation of moving upward. So they are sensing things in perpendicular directions, right? Now, how does the structure of the macula look like? Briefly, on the left side here, you can see the static macula, right? Then again, you have the bunch of sensory cells, which we refer to as hair cells. There are a bunch of supporting cells, which can modify the response of hair cells. Not a big deal. They have cilia that extend to a gelatinous material, which we refer to here as otolytic membrane. And this is the same story. The fluid here moves around, the otolytic membrane moves around, and as it moves around, it causes fluctuations or bending of the cilia, which will, as we said, cause depolarization of the cells. You kind of do not have the push-pull system here. The right and left side provide the same either polarization, either hyperpolarization or depolarization, depending on which direction you move around, and these signals complement each other. They're not like a push-pull system here. But what's cool, and a lot of people know kind of about it, and you might ask you about it, are these bunch of crystals. These crystals that are on the otolytic membrane, and we call them otoconia, or we call them otolith, because they're stone, and lith means stone. I think it's Latin for stone, and it's in the ear, right? Otolith. And they're made of calcium carbonate. They're pretty small ones. Here I've written the size, 0.1 to 30 micrometers. Just to give you a reference, a red blood cell is almost 7 micrometers in its diameters, right? So they could be smaller, much smaller than a red blood cell, and in their biggest size, they are like, let's say, roughly 4 times the size of a red blood cell. So they're very tiny. But they are clinically important. There are diseases which we think occur because, and the reason why they help you is because they have a different density, so they help the movement to occur more, let's say, more efficiently, and the cilia to move more efficiently. And sometimes when they are displaced or not in the correct location, they might cause problems. They might make you feel like your head is rotating or your head is moving around. And this disease is called benign paroxysmal vertigo, right? And there are it's hard to believe, but there are actually maneuvers that can reposition these stones and help these patients get better. Also by time it gets better as they kind of bounce around and find or fall back into correct place. But this is really a theory behind what this happens. But interesting facts. And another point I want to mention, and this is kind of, I try to put in these little stories for you guys to make it a bit more interesting, that if you didn't have gravity, all this the whole story of inertia and stuff lagging behind is kind of because of gravity. And if you do not have gravity, if these do not weigh so much, they won't make that much relative movement compared to one another. So when you do not have gravity, you really cannot sense these movements as well as you would sense them on Earth. So if you're on moon or another planet on space where there's much less gravity, your sensation of moving up and down will be very much diminished. And actually, there's a story about I forgot his name. Oh, Neil Armstrong, that they send him to on the first mission before going to the moon, before going to the space. They send him kind of out of Earth. He was not out of pull of gravity. It was just send him out, and he was supposed to come back with a parachute, right? Believe me, this happened. They send him out really high into space, but still within the gravity of Earth. He has all those breathing equipments with himself, and he was supposed to parachute down. And when he came down, he tells a very interesting story. He says, for some moments, I was panicking after I opened my parachute because I feel I was not moving downwards. Now, here obviously he did not have any visual reference to sense his movement, right? Because everything is so far and so big, it doesn't look like you're moving. Plus, he was going down. He was not out of gravity. That mission was successful. He came back to Earth by the pull of gravity, but with his parachute. But he could not really sense that he's coming down because the gravity was so little at that point that these systems were not working, so he could not sense movement. I'm sure you're appreciating my little stories here. So let's move forward. Okay, so we talked about the sensory part. Now, you see here these nerves, right, which are connected into the sensory organs. You can see these nerves, these afferent nerves, which are supposed to take the information and take it to the central nervous system. These nerves belong to the vestibular nerve, right? Nerve number 8, vestibulocochlear nerve, particularly the vestibular section here. And the cells, let me see if I have a better image. Yeah. So look at here. This is your inner ear, right? The canals and everything. And here is the nerves, right? The afferent, and they go to the vestibular ganglion. Now, what is a ganglion? Guys, ganglion is a nerve body. It's a fancy name for a nerve cell body which is outside the central nervous system, right? And it has two projections, one going to the peripheral sensory organ, one going to the central nervous system. Here is your vestibular nuclei. You have 4 sets of vestibular nuclei on each side. I just want to mention one point. These vestibular ganglion cells are kind of a unique cells because they are so-called bipolar cells, which means they have two extensions of their cell body going to each sides. The other peripheral nervous system are usually referred to as pseudo-unipolar, which means it's really one projection which then becomes 2, but these have 2. Right, so these are, if I remember correctly, these are the only bipolar nerves that you have within your peripheral nervous system. All the others are pseudo-unipolar or something else. They're not bipolar. If I'm not mistaken, not sure about that. You need to check it. But anyway, you have these bipolar neurons that get the information. These vestibular ganglions, you're located within your auditory canal, right? So the distal 1/3 of auditory canal is housing these cell bodies. One projection here, the other projection goes to the central nervous system, and it connects to the vestibular nuclei and provides information to the vestibular nuclei. Now, I will later on really talk about the vestibular nuclei, because vestibular nuclei are very unique. They do not only receive information from the vestibular system, but also from the cerebellum and also from your retina. But I will talk about this later on. And I will talk about the projections as well. So let's come here. Okay, I told you. So we talked about the ganglion. Where does the ganglion information go? It goes to the vestibular nuclei in your brain stem. Look, guys, what is your brain stem? It's the stem of your brain, right? And it has three sections. Up from here, that would be the midbrain. In the middle here, you have the pons, and here you have the medulla oblongata. So at the junction of the pons and medulla, so basically in the rostral I should say in the rostral medulla and caudal pons, but easier said, in the pontomedullary junction, you have a bunch of nuclei. There are actually four of them, which are taking up this space at the pontomedullary junction, and these are four separate nuclei, and they receive the vestibular information. But not only the vestibular nuclei receive afferent information from the vestibular nerve, but also from non-vestibular sources. And this is super, super important. The vestibular nuclei have afferent, we're not talking about projections, afferent incoming information. They receive incoming information not only from the vestibular system, not only from the vestibular end organs, but also from non-vestibular ones. One of them is from your retina, your visual afferents, right? This is a so-called retinal slip. So the way the images are moving on your retina, how fast they're moving on your retina, to what direction they're moving on your retina, that information is also relayed to these nuclei. And that is important if you want to understand the nystagmus, or so-called optokinetic reflex. So later on I will talk about the nystagmus and tell you how vestibular inputs, essentially, for example, turning your head around, can cause nystagmus. But also an object, if this is your eye, and something moves across your visual field, that will also cause nystagmus, and your head has not turned. Right? This movement can also cause nystagmus. This is called optokinetic reflex, also called train nystagmus, because imagine if you're sitting on a train, that basically means your head is not moving around, but the trees or the electric poles that you see from the train window is a visual field which is moving around, and that will cause nystagmus, which means your eye will follow it and then come back. Will follow it and then come back. But don't worry, we'll talk about this stuff later on. Then you also have the spinal input. Makes sense. You have a spinal input. What kind of spinal input? Proprioceptive. Now, what is proprioceptive? It basically means you know where different parts of your body are located relative to each other. How you know how much each muscle is contracting, you know the length of each muscle, and you know the angle at which every joint is located. Very, very important information. These are called proprioceptive information. These information are sensed by particular sensors in your joint capsule, in your muscle spindles, blah blah blah. They go to cuneate and whatever, I don't remember the names really, cuneate nucleus and other nuclei. This is a posterior column system, right? This is a posterior column system located in the posterior. A highly myelinated information travels very fast along this system, and they convey information about where different things are located relative to each other. There is a whole section of your cerebellum that is dedicated to communication with your vestibular system. This is called a vestibulocerebellum, but we don't want to get into those stuff. The gist of the matter, not only vestibular but also non-vestibular inputs are coming in, and this is important as far as nystagmus is concerned, because you can have optokinetic reflex, and that is the explanation behind the physiological normal occurrence of trained nystagmus. What are the functions? Well, I really made two important functions for you. As I mean, we already talked a little bit about function. It's the equilibrium and balance, which are maintained by the VSR, vestibulospinal reflex, and the basically the stabilization of your visual field, which is provided by the vestibulo-ocular reflex. Now, I want to talk more in depth about VOR, but let's briefly cover the VSR. The VSR says that your vestibular system can send information via directly and indirectly via vestibulospinal tracts and reticulospinal tracts to modify the activity of the cells in the anterior horn of your spinal column, which supply muscles, and they can control your muscle tone, and it does a bunch of stuff, right? It maintains your equilibrium, it maintains your posture, and importantly, it also maintains your head position. So not only you're controlling the direction of your gaze and your eyeball, but you also need to have a coordinated movement of your head, which is provided with the VSR. So this image here is kind of summary of what I told you. But let's briefly look at it. Here is your vestibular end organs. These are the four nuclei that we talked about at the pontomedullary junction, and they project. They have projections to your eye. Cranial nerve number 3, 4, and 6 activity can be modified. These are the nerves that supply the muscles of the eye, right? The external ocular muscles. These are the muscles that move your eyeball around. And this is the basic of how VOR happens, the vestibulocular reflex. But this stuff also project, look, to the anterior horn, so you can control your muscles, particularly proximal muscles, because it doesn't matter what your pinky finger does, but it matters what your core abdominal muscles do. It matters what your core or what your proximal muscles in the upper and lower limb do. Those will give your posture and your equilibrium. But also look here, trapezius and sternocleidomastoid, which can help you direct your head towards the target that which you're trying to look at when your body moves around, right? So this is the VSR. Okay. I'll come back to this later on if we have time. Let's move on. Okay, I told you, if you want to understand nystagmus, you need to understand VOR. And the VOR is best studied and best understood in the horizontal direction. So we will take the horizontal direction, and I will explain you in more details what VOR is all about and what the hell is nystagmus. Alrighty. Look, what do you think this is? This is your nose. This is one of your eyes. Okay, this is one of your eyes. This is one of your eyes. Imagine we're looking from top. This is your right eye. This is the left eye, right? We're looking from the top, right? So this is essentially the anterior direction, all right? Now, here you have muscles connecting to your eyeballs. This is the lateral rectus. This is the medial rectus. This is the medial rectus. This is the lateral rectus. What muscles supply these? Lateral rectus by cranial nerve number 6, abducent, and medial by the cranial nerve number 3, oculomotor. Look, imagine you are trying to look at this target here, right? And then your head turns around in the horizontal section to the right. So this is the direction of the head rotation. rotation. And you want to keep looking at the target. So your eyes have to perform a compensatory movement, obviously to the opposite direction, to the left, in order for you to keep looking at this target. So what you need to do is to activate the medial rectus on the right eye, so to activate the ocular motor nerve on the right side, and also to activate the lateral rectus or the abducens nerve on the left side in order to perform a conjugated, a slow movement to the left as your head is rotating to the right. Are you following me? This is so simple. And this is how you can keep looking at the same target. Now, what I want you to do, and please do this with me, take your finger and hold it in front of your eyes. Keep looking at the tip of the finger. And now start shaking your head left and right and keep looking at it. It's amazing. You can surprisingly keep looking at the target even though you're vigorously shaking your head left and right. This is because this VOR will perform a compensatory movement and you can keep your gaze at the target. Now, what happens when your head moves around too much and basically there is no other place left for further rotation of your eyeballs to the left? They will jump back to the center of the gaze. So this is called a nystagmus, guys. This is called a nystagmus. So nystagmus is composed of a pursutic movement, of a slow pursutic movement that tries to compensate for the rotation of the head. And once you're out of the range of the movement of your eyes, a reflex, this is caused by the oculomotor nuclei, by the way, but it's a reflex which will suddenly move the eyeballs back to the center of the gaze because the target is out of your visual field. It can no longer be at your gaze. It's out of your visual field. Slow movement, fast movement. Slow movement, fast movement. Slow movement, fast movement, right? This is a nystagmus. And in this example, this is a physiological nystagmus. This is a normal nystagmus. It's a good nystagmus. Here's the same picture, explaining you the stuff. So, look, guys. Look. This is the semicircular canal. This is the semicircular canal on the left side. This is the semicircular canal on the right side. They are both providing certain level of activity. What happens when you rotate your head to the right? The activity on this side decreases, the activity on the other side increases. These signals are sent to the vestibular nucleus. And by the way, these vestibular nuclei are talking to each other, right? So you might be wondering, why is it only shown in this one set? Well, because we're trying to simplify it, right? The reality is that there are commissural fibers which are crossing between the vestibular nuclei, but we don't want to make it complicated. So this vestibular nucleus here also senses the fact that there's less signal from this side. But let's put that aside. The point is that the combination, this push and pull system, tells this vestibular nucleus that your head is moving to the right. So it sends information directly to the oculomotor nerve on the right side. So the medial rectus contracts, moving your eye to the left. And the abducens on the other side, so the lateral rectus will contract, moving the left eye to the left. So this movement of the eyeball will set off the movement of your head, so the gaze does not change. It keeps itself on the target, right? This slow movement is called the slow component of the nystagmus, the so-called pursutic movement, because it is pursuing, it is following the target. And then things move. It has a range. The target goes out of the range of your visual field, so then a reflex happens which will suddenly take your gaze back to the central gaze. This is called the fast component of the nystagmus, also referred as the saccadic movement, saccade, or simply the saccade, the saccade limb of the nystagmus. The slow fast component, the slow fast component. I hope you're still following me. Now, I want to tell you something very, very, very important. And at the end of these lectures, I will actually go into more details about it. But since we have these pictures, I want to make this, and this clinical correlate is actually here. I want to make it a bit more clear. What happens? What happens if I have an ear problem, an ear disease, right? And my left ear is not working. It's not sending signals, right? It's not sending signals. Maybe there is something wrong with the endolymph. Maybe there's something wrong with with those otolytic stuff, with those crystals. Maybe something is wrong with the nerve. Somehow a peripheral problem within the inner ear which is inhibiting the signals. Then you will have too much signals from the right side. So your head thinks, or let's say your brain thinks that your head is rotating to the right. It's not rotating to the right, but it thinks it's rotating to the right, so it's starting to cause nystagmus. Do you get it? This is a pathological nystagmus. Because of a problem in the ear, you sense, your brain senses that the head is rotating to the right. So you will have a nystagmus, right? Now, rule number one. Rule number one. The direction of nystagmus is named after the fast component. So when I say nystagmus to the right, I mean the fast component of the nystagmus is to the right. When I say nystagmus is to the left, I mean the fast component of the nystagmus is to the left. Okay. So here's a super important thing. When you have a peripheral region, the direction of the nystagmus is towards the healthy ear. I'm going to repeat this one more time because this will be in your exam. If you take a topic of nystagmus, 100% sure they will ask you this. When you have a peripheral lesion that causes diminished signal from that side, and usually peripheral lesions do cause that, then the direction of the nystagmus, which means the direction of the fast component, is towards the healthy side. Why? Because of all the things we just explained here. So you can rewind the video and see why when your head moves to the right, or when your brain thinks your head is moving to the right, you will have a nystagmus with a fast component to the same side, toward the right side, and the pursutic movement to the opposite side. Very important, but I will come back to it later again. Okay, so we are becoming more and more clinically relevant here. But what is a nystagmus? Nystagmus is a conjugated rhythmic eye movement. What does it mean? It's rhythmic. It happens again and again and again. It doesn't happen once. It's conjugated. Both eyes do it together. Now, obviously, if someone is suffering from a strabismus or some form of problem, it might not be really conjugated. But as a rule of thumb, it has to be a conjugated rhythmic eye movement. There are 3 types of nystagmus. There's the spontaneous nystagmus, right? There's a provoked and induced one. The induced one is a physiological one. It normally happens. The induced nystagmus is a physiological nystagmus. It normally happens. It's the same story as being in a train and the targets are moving past by you and you perform a pursutic movement to follow the target, and then it moves out of the range of your movement of your eyeball, and a saccade the opposite direction, and then again slow saccade in order to move these following targets, these moving targets. physiological one. Then you have two pathological ones. The top two here, the top two in this list are pathological and not normal. They're abnormal. You have the spontaneous and provoked one. Provoked one is simple. It's positional. It happens when you are lying down or sitting up. Usually it's kind of a rotation like that, which provokes the nystagmus. It also provokes the vomiting or the sensation of vertigo. The patient feels that the world is turning around or that they are turning around themselves. So things like that. And there's a spontaneous form, which is there, not really provoked by a movement of your body, and it is present within the 30-degree of visual field. And you always have to check it to see if it's what do I mean when I say 30 degrees of visual field? Imagine this is the dead ahead gaze. You have to see it within 30 degrees. Within 30 degrees here. Not really here. If you see it here, it just might be a physiological one, because the target is if the target that the patient is looking at is so off to the side, this might just be a pursuit and a saccade which is physiological. It must be present within 30 degree, either in the horizontal section or in the vertical section. So imagine a cone, right, with 30 degree. That cone, like a cone coming out of your eyeball, and its degree is 30 degrees. Within that cone, you need to see the nystagmus. That's what we call it spontaneous. Now, it has two components. Not always slow and fast. I will talk about this later on. There's an exception, but usually there's a slow pursuic movement, and then it's followed by a fast movement. And whenever we have the pathological nystagmus, really what is pathological is the slow limb, right? The slow component is usually the pathological component. Here the slow component was happening to the left because we did not have signal coming from your left ear. So the pathologic component is the slow component. The fast component is simply a consequence of the oculomotor reflex, a central reflex, right? It's not the real pathology. The real pathology is the slow component, but unfortunately nystagmus is named after the fast component. And the reason why it's named after the fast component is because the slow component is so hard to detect on the patient's eye, but the fast component is fast, so you detect it much better. That's why they name the direction after the fast direction, because that's the easiest direction to notice when you're examining a patient with nystagmus. Moreover, we have these always check it with Fresnel glasses. This is a particular type of glasses. They kind of blow up your patient's eyeball, and it's much easier to see the nystagmus, and can actually count them. I will come back to the Alexander's law, but I would like to talk about spontaneous nystagmus. Provoked nystagmus is important as well because of a disease called benign paroxysmal positional vertigo, which is a very common cause of nystagmus and vertigo. But let's talk about the spontaneous one. There are three types of spontaneous nystagmus. The vestibular, let me highlight this for you. The vestibular type, the fixation type, and the gaze-evoked nystagmus. What is the vestibular one? Vestibular one says it's a type that happens due to a problem with the vestibular system. It could be peripheral or central, but let me tell you, it is almost always peripheral. It is rarely that some sort of a tumor or a vascular region, a hemorrhage, or an ischemic infarct would particularly and solely affect the central vestibular system, right? So it is rarely a fact that you need to kind of deduce a central problem only by the symptom of nystagmus. Usually, almost always, to be honest with you, it's a peripheral problem. It's either the sensory organs or the vestibular nerve, right? Rarely a lesion of the brainstem with the vestibular nuclei. It could happen, but usually those blood vessels supply multiple nuclei, so there would be other symptoms as well. So you wouldn't really need to kind of understand, oh, there might have been a brainstem infarct just because someone has nystagmus. Usually, it would have basically neurological deficits of other nuclei or central parts of the brain, which will help you understand that. So really think of it as peripheral lesions. uh, and this is the classical nystagmus. This is what I was telling you all about. This is the one that has the jerky movement. Look, the jerky movement. So the fast and the slow component. This is the most common type that you need to know about, right? And it's almost always peripheral. And as we said, it beats, well, it says generally beats, because if it's central, it doesn't have to do that, but it's not central in majority of cases. So almost always it beats towards the healthy side. When it says it beats towards the healthy side, it means the spontaneous or the fast component is towards the healthy side. Why? Because of here, because I already told you, when there's a peripheral lesion on the left side, your brain thinks your head is tilting to the right, so it will make a slow movement to the left, and then the saccade, the fast phase, will be to the right, which means to the side of the healthy ear. That is why. And now I want to introduce you to the Alexander law. There are three laws. Law number one, fast fade is to, so first of all, what does Alexander law apply to? It applies to spontaneous nystagmus, this one that we talked about, occurring after acute unilateral vestibular loss. So peripheral problem. But as I said, in almost the majority of cases, a spontaneous form is a peripheral form. So usually Alexander law does apply to spontaneous nystagmus. The fast phase is towards healthy ear. I already established that. Nystagmus is graded or is greater with gaze towards the nystagmus direction. So what is it? What does it mean? If you ask this patient to look to the right, well, you already know the nystagmus in this patient. Imagine this patient has a problem in the left ear. Alexander rule number one. Rule number one tells you that the direction of the nystagmus would be to the healthy ear, so it will be to the right. So the fast component is to the right. And if you ask the patient to look at right, you will see this nystagmus gets faster and more frequent. So it gets exacerbated. And if the patient looks away, it actually gets less severe. So when the gaze is towards the direction of the healthy side, towards the direction of the nystagmus, away from the direction of the lesion, then the nystagmus gets exacerbated. Faster component becomes becomes more rapid and more frequent, right? And before getting to number three, let me tell you rule number two is the basis for grading of the nystagmus. And here is the grading. First degree is present only during gaze in the direction of nystagmus. So it's so little that you would detect it when the patient is looking to the same direction as the nystagmus, so then it shows itself. And the third degree is such a severe nystagmus that when the patient is even looking away from the direction of the nystagmus, you can still see the nystagmus. Now, just if you read through this text that I provided you, I'm sure you will understand it if you could not understand it from my words. Rule number three. If the patient closes their eyes, the nystagmus gets worse. And please do not ask me How would I know the nystagmus is getting worse if someone closing their eyes? We have methods to do that. The same way that we realize there is a rapid eye movement part of the sleep, that when you're sleeping, we have ways of detecting which muscles are contracting in your eyeball even when your eyes are closed. But believe me, this happens. So when the patient is denied vision, when we do not ask them to look at something in particular, for example, we can deny their target or their vision by closing their eyes, the nystagmus gets worse. Okay, this is about the vestibular spontaneous nystagmus. Fixation nystagmus. Read through the text, but the most important part, this is a pendular type of nystagmus. So like a pendulum of a watch, like which moves like this. There is no fast and a slow component. Both components have the same speed. This is kind of a congenital problem, and not a big deal. You don't need to treat it. All right, so kind of forget about it. But you might hear the term pendular nystagmus. Gaze evoked, the third one, gaze evoked nystagmus. Very important. You need to know about it. You see it in the hospital, especially in the Western countries, when there are a lot of alcoholic people and people with Wernicke-Korsakoff problems. You'll see this frequently in the neurology wards when they admit these patients with chronic alcohol poisoning. Super important difference between gaze evoked and vestibular form. Vestibular form is always to the same direction. When it's to the right, it's always to the right. If the patient looks at the right, it gets worse. When they look at the left, it gets less, but it's always to the right, always to the same direction. Whereas a gaze evoked nystagmus is a type of central nystagmus, and this is the most common type of central nystagmus. And the direction of the nystagmus depends on the direction of the gaze. So when you're doing the H test, when they ask the patient to follow your, if you don't know what the H test is, please go Google it. It's a way of testing the movement of the eye when you show the patient a target to look at, and the target moves in the shape of an H, so you can check all the different quadrants that the eyeball can move around. Okay. Now, when you're doing the H test for the patient, because this is how you check the cranial nerve number 1 movement, you see that the patient has nystagmus to the right when they are looking at the right, to the left when they are looking at the left, upwards when they are looking upwards, downwards when they are looking downwards. That's why we call it gaze evoked, because the gaze evokes it to the same side. So it's not to the same direction, it's always to the same direction of the gaze. And this is the central type of gaze. Now, theoretically, spontaneous vestibular nystagmus could also be a central nystagmus, but rarely. However, the most common type of central nystagmus that you would see is the gaze evoked type, when the direction of the nystagmus is towards the direction of the gaze. Now, why does this happen? Barbiturates. Barbiturates is essentially the same thing as alcohol, isn't it? If you don't believe me, go check how barbiturates function and how alcohol affects your brain. And you see people with Korsakoff, Wernicke-Korsakoff and stuff like that, chronic alcohol problems, and I hate to say, but this beautiful nystagmus. So it's a great opportunity to go check these patients who unfortunately have this problem. So central type here. I don't want to talk about this stuff. I'm going to talk about this last part here because this is super important, because this is super clinically relevant, and 100% they will ask you this if you take this topic on ENT, on neurology, all right? There are a bunch of tests that you could perform to check for nystagmus. For example, one of them is to ask a patient to walk on a straight line, and if they have problem with the vestibular system, not only they would have nystagmus, but they would fail on this straight walking test. They would stray away from the straight line. Or for example, on a Romberg test, when you ask them to stand, they will fall down to one side. Or if you ask the patient to sit down and move their hand up and down between their knee and a target that you're providing, which is your arm, and then you tell them to close their eyes, their arm is not going straight up and down, but deviating from the target, going to the left or to the right of the target. So there are a bunch of other tests by which you can check the vestibular system. And what they want you to know is to know if I have nystagmus to the left or nystagmus to the right, what would happen in the straight walking test? What would happen in the Romberg test? What would happen into this test? I forgot the name of this test. Nystagmus to the right, which side they would go, which side they would fall, which side their arm would deviate, depending on whether the lesion is central or peripheral. And people keep forgetting this, but they keep forgetting it because they do not know how to understand it. Now I tell you how to understand it. And you can always deduce the results and you will never forget it. Let me take a sip of my tea. Okay, listen to me carefully. This is a straight line. This is a person. This is the nose, the eyes, right side, left side. They're supposed to. A normal person can walk on a straight line with their eyes closed. By the way, you have to close your eyes with their eyes closed, right? I mean, not for long, maybe for 10 meters, for example, or 5 meters. So 5 steps. This is not, we can walk straight for that matter because we have a normal functional vestibular system. But imagine someone has a problem with their left ear, No signal coming from the left vestibular horizontal canal or semicircular canal, right? So relatively more signal is coming from the right side. So the patient thinks stuff are rotating to the right. So for me to go on a straight line, I have to go to the left side. Do you get it? When the problem is on the left side, you think you're rotating to the right and you're asked to go on a straight line. So you would try to compensate for that in your head by moving to the left. But you're not rotating to the right. The problem is in your ear. So you actually end up deviating from the straight line to the left. The same reason why the pursutic movement, the slow component of nystagmus, is towards the left, right? The same reason underlines why you would deviate to the left. So the nystagmus is to the right. The nystagmus is to the right because nystagmus is named after the fast component. But you deviate to the left. On the Romberg test, you would fall to your left side. On the test that I don't remember the name, your hand will deviate from the target by missing it to its left. Once again, nystagmus to right, everything to the left. This is if you have a peripheral region. I love my English pronunciation when I try to speak so classically and then you fuck it up. Okay, peripheral lesion. Nystagmus to the opposite side of lesion, to the healthy side, and everything else the opposite direction of nystagmus. So you deviate from the straight line to the opposite side. You fall to the opposite side. Your moves miss a target to the opposite side. So simple. And this is what we call harmonic symptoms. And you're like, what the fuck? What is harmonic about having nystagmus to the right and everything else to the left? But remember, guys, the pathological direction of nystagmus is the slow component. So actually, the slow component is also to the left, which means it's harmonic with everything else. But unfortunately, nystagmus It's named after the fast component. So nystagmus to the right, everything else to the left. This is harmonic. And this is a peripheral lesion. If the lesion was central, it would be disharmonic. It would mean the nystagmus would be to the right, but also the deviation would be to the right. Also the falling would be to the right. Also the hand would miss the signal to the right, right? So this stuff is written for you here. Harmonic vestibular syndrome, it means it's peripheral. It's peripheral, right? Nystagmus is to the right, but everything else is to the left. Disharmonic, nystagmus is to the right, and everything else is to the same direction. Now, I told you that the fact of the matter is that here you see it says rarely harmonic, rarely harmonic. It is kind of because this vestibular spontaneous nystagmus could be rarely central. Could be rarely central. Mostly it's peripheral, could be rarely central. That's why it happens. And most of the time the central is this one. But do not get fussy about it, right? Understands the basic. This is the super most important thing I want to say. One more thing, the vegetative symptoms. The vegetative symptoms. What do we mean by vegetative symptoms? We mean vomiting and sweating and being nauseated. You don't necessarily vomit, but you feel like you want to vomit. These are much more exacerbated in the peripheral one. Right? They ask you about it. It is important. Another thing that I wanted to mention, that peripheral one is never ever vertical. Never ever. So if it happens vertically, like here, it's central. If it can also happen vertically, it's central. All right. Now, hopefully you followed me this far. I will hopefully make another video talking about Meniere's benign paroxysmal positional vertigo and the vestibular neuritis, which are common causes of peripheral nystagmus and vertigo. By the way, I think I really didn't touch on vertigo. Vertigo is a sensation that happens due to these problems. Vertigo means that it means that you feel either the world is rotating around you or you are rotating around yourself. And the closest it can give an example is that when you are really drunk and you go to bed and everything feels like rotating around, right? That is actually a kind of central type of problem. This is, guys, this is alcohol poisoning, alcohol intoxication, right? It's amazing. So when people say, "Oh, I have vertigo," you have to make sure that they're not dizzy, they're not lightheaded, that they don't have cardiovascular problems that is causing this kind of, or they're not hypovolemic that's causing lightheadedness. A true vertigo has to be a true sensation of rotation, either you around yourself or the world around yourself. Okay. By the way, when you're drunk and you go to bed and things feel like moving around you, what happens when you close your eyes? It gets even worse. Isn't medicine beautiful? Thank you for listening to me. See you in the next video.